Okay, so formally starting this lecture. So this time I'm going to talk about this thing, major transfusion protocols in pediatric practice. This was on the request of Helen that she requested this topic, and I understand this is a bit tricky because we don't get the chance to see that many transfusion related, cases in the emergency department. Though I think in the major trauma centers in the tertiary care hospital, they do see it on a regular basis. Maybe here in some of the surgical wards, we don't have a pediatric surgical ward, but in some of the wards, like where there are major surgeries, uh, they might sometimes, once in a while, see a case which has got massive blood loss because of one reason or the other reason. I understand in an emergency department setting, most of the times, if we ever get a chance to see these things, would be basically trauma related, or maybe a patient who has got some chronic issues, like let's say end stage liver cirrhosis, and all of a sudden develops bleeding varices, and that usually leads to massive hematemesis, things like that. So we might come across once in a while, but I don't think I've seen ever in the last 8 years since I've been here in Medway. But again, still we need to be well prepared about these things in case once in a while if we do get a chance to handle these cases. So this lecture is about the step-by-step guidance to manage major hemorrhage in children. So I will try to cover both like traumatic and non-traumatic bleeding emergencies. Now before I start, I need to give you an overview of what is the difference between blood and the other types of fluids that we use in resuscitation. So normally IV fluids like saline or dextrose, we use it like candies in emergency department without giving it a second thought. Somebody who's got we think he's in shock or has got developed some fluid loss or maybe dehydrated, we just write IV fluids and you started giving it a second because it's there on the top of their memory. Blood is not like this. I mean, both are used for resuscitation. Both are used when there is shock. The only one thing, blood would be given when there is hemorrhagic shock. IV fluids are given when there is sort of a non-hemorrhagic shock, like septic shock or other types of cardiogenic shock, things like. But why do we have to think so much about the blood as compared to the IV fluids? The thing that the IV fluids are the same all over the world. Wherever you use it, it's the same water, it's the same salt, it's the same ratio that you mix. Blood is not the same. Obviously, I mean, we all have got blood. It's the same red color, but there's difference between your blood and my blood. The reason being that the red blood cells have got so much things on them. There are antigens, there are antibodies, there are white blood cells, there are so many other things that can basically cause problem if they are mismatched between the donor and the recipient. So if you take a bag of blood, let's say 1 unit of blood, usually it's red, like if you take it from a fresh donor. But if you put it in a machine, you centrifuge it, you agitate the blood for, let's say, half an hour or something. So you would get something like this. Okay, so here if you see a blood bag where you can see a dark sediment in the bottom. Then you've got a sort of a layer, brownish layer between this yellowish layer at the top and the dark beefy colored solution at the bottom. So that thing, actually what happens when you agitate the blood gets sort of separated between its components. So at the bottom you've got this dark red portion. These are the red blood cells. So these are the red blood cells that usually sediment at the bottom. Then you have got this buffy coat, this small layer, okay, darkish layer between the lightish layer above and the dark layer below. That's the buffy coat. So the buffy coat actually contains your white blood cells, all the different types of lymphocyte, neutrophils, platelets. They are in this portion. While this portion, the biggest part, that is plasma basically. So that contains your antibodies, your clotting factors, things like that. So you know that blood basically is 45% are your formed components. That is, we also call it hematocrit, your red blood cells and other stuff, and 55% is plasma. You can see almost like this is 55% plasma and 45% blood. So normally blood is given can be given in two forms. It can be given as a whole blood, like the blood that is in your body. So you give it the same way that you lose it. So it's a whole blood. containing everything, containing red blood cells, containing white blood cells, containing platelets, containing antibodies. Obviously, that has to be mashed, but you give the whole blood. Or you can, what you do, you can process the blood and make, or what you call, separate different components from that. So you can separate the red blood cells from it, you can separate the platelets from it, you can separate the plasma bit from it, and you can separate the clotting factors from it. So you can separate all these things and you can give them separately to the patient. So if you see here on this right side, this is the separated plasma part, so fresh frozen plasma. So as you can see, this is the yellowish part. So this has been removed from the whole blood and a separate pack has been made. You can see this is the AB positive or negative fresh frozen plasma. Then here you can see this is the sort of more orangish thing. This is the cryoprecipitate. So cryoprecipitate is actually your clotting factor. So it is further extracted from the plasma. Plasma contains your antibodies. So from the plasma, if you extract the clotting factor, especially fibrinogen, then you call it cryoprecipitate. And this is the yellowish portion. This is the platelets. So you can extract red blood cells. We call them packed red blood cells. You can extract plasma. You can extract cryo, and you can extract platelets from the blood and give them separately. Now, the million-dollar question is, why don't we give the blood as a whole? Why we have to give these products separately? Any idea? No, in fact, it's the opposite. Basically, it's more logistically, it's more difficult to separate all these things because it's easy. You take the blood from a donor and you give it to another one. So logistically, it's easy. One bag comes out and it goes in another person, provided they are obviously, group and save, mash and things like that. But like preparing it, it requires resources. It requires special techniques. It requires special, refrigerators to store them. And obviously, the work is multiplied. But why? Excellent. That is one thing, when they require these things on a, on a like a separate basis. For example, somebody who's only suffering from like a clotting factor deficiency or things like that. So you just need to give them some clotting factors like hemophilic patients. But in a trauma patient, let's say somebody who comes in emergency department setting and is losing blood from whatever source, whether it's trauma related or non-trauma related. So the person is losing blood as whole. He's not losing let's say packed blood cells separately or plasma separately. The blood is coming out. So why not the blood to go back in the same form in which it is coming out? Not necessarily. I mean, they are always sort of you have to mesh them, so cross match them. Okay, let me give you the answer. The reason lies because the components of the whole blood have got different shelf lives. That's the reason. For example, if you look at red blood cells can live for up to 120 days. That's how much, almost 3-4 months. Okay, they've got a shelf life of the white blood cells and platelets. They have got a shelf life of just a week to 10 days. So within 10 days, if you you have taken blood from someone and you store it in a refrigerator, so what would happen? After a week's time, red blood cells would still be alive, but white blood cells would be gone. Platelets would be dead in that. And obviously the plasma proteins would be there. But you will see the white blood cells and the platelet portions would be gone because they've got a small shelf life. So after a week's time, if you're going to give this whole blood, what are you giving? Basically, you are just giving the plasma and you are giving the red blood cells. You're not giving any platelets. You're not giving any white blood because they have already died. So what happened when these cells, they would die, they break down within that bag, that would also lead to release of lot of potassium. What would happen when you give this blood, like let's say where the the white blood cells and the platelets have broken down, that would contain dangerously large amount of potassium, which can cause heart failure, which can cause arrhythmias. So fresh blood can only be given on an emergency basis if it is freshly available. Like for example, if somebody is a donor, let's say somebody comes and he say like, I am a relative of this patient, I am willing to give blood, okay, and you match them, they are matched, okay, and then fresh blood comes out from one person. Within 3 or 4 hours it goes into the recipient. Fine, well and good, that's the best thing. That's what they do in war zones. And I tell you one thing, I mean, I haven't had a single case of this massive transfusion here in UK, but back when I was in Pakistan, we used to see this on a regular basis, because we used to get many patients of bomb blast injuries, massive polytraumas, where they were bleeding from almost like every major vessel of the body, and that was like a sort of a war zone situation. You had to do something there, and then you didn't have time to activate MTP or something. Whatever you had at your hands, you had to give it in them. Okay, so massive transfusion, whole blood transfusion. So whole blood usually works when you have got it freshly available and you give it within a couple of hours at that point. So obviously everything is fresh. The components of the blood are alive and you can give it. But you never know if somebody comes, okay, you never know for how long the blood has been stored. So what the hematologists do, they take fresh donor blood and they process it and they make separate components from that. So packed red blood cells, they separate it, they make a separate bag out of it that they know has to be utilized within like 120 days. Fresh frozen plasma, they actually because that is antibodies, that doesn't contain any like live cells, so that they freeze it. So after like that can be kept for another like couple of months into the into the appropriate refrigerators in frozen form. The platelets and the cryo, they separately prepare it, and that has to be used within a week's time. So within a week's time, if it is not used, they have to discard it. It's like just goes into the bin. So if it is needed, it will be just utilized within the. That's why the major trauma centers which are like maintaining the blood banks or something. So if somebody requires, even in the the satellite centers, they just rush the blood over there. So it is utilized, because if it is lying there and it's not utilized, it's gonna expire within a week's time, especially the platelets and the cryoprecipitate. So the hematologists, and there are special machines for that, what they do is they take this whole blood, they process it, they centrifuge it, and then they separate these elements. So packed red blood cells are put in a separate bag, plasma is put in a separate bag and frozen, and then cryoprecipitate and platelets are separately stored in different bags, and then they are sort of dispensed according to the needs. Now when somebody is losing full blood, so what you will do, now you cannot give him whole, because you don't know for how long that if whether you would be having fresh blood available at that point or not. But in freezer you've got all these things available in in the hematology or the blood bank. What happens is that they would issue these things in such a ratio that when you finally put all these together in the patient, that would reconstitute the whole thing as a whole blood. So you will be giving them packed red blood cells, you will be giving them fresh frozen plasma, you will be giving them cryoprecipitate, and you will be giving them platelets. So finally, by the end of the day, though you are infusing all these things separately, the final composition would still be the same. So blood is coming out in toto out, but you are putting it back in small bits and pieces, like red blood cells and then platelets and then plasma and then like this and that. And finally inside the body, they all combine together to form the actual blood. So this is one thing. Number two, we always have to match, like IV fluids are the same IV fluids which can be given any part. Blood is not like that. Blood has to be matched with the recipient. The donor and the recipient blood has to be matched. Why? Because the red blood cells have got antigens on them. So if you give blood to someone, what would happen? These antigens would be taken as foreign, and the recipient antibodies would attack that. Or what happens? The antibodies in whole blood, especially if you're given fresh frozen plasma, the antibodies here, what would happen? They would attack the recipient's RBCs. So in both cases, what would happen? The recipient is at loss, because either his antibodies are attacking the donor's RBCs or the donor's antibodies are attacking the recipient RBCs. What would happen if you give something and then it further becomes a battleground? The red blood cells get further lysed. That would lead to further problem. That's why transfusions are always handled very carefully, because if a little thing goes wrong, that can have detrimental consequences for the patient. Not only that, it would lead to, let's say, fluid overload, volume overload, that can cause lung injury, that can cause kidney injury, that can cause heart failure, that can cause so many things. So that's why what we do is, like, we have to match the recipient and donor bloods with one another, so that to see that they are not attacking one another. But obviously in emergency setting, that's not possible. That's not possible that you'll have the time to see this and that. So what will you do? You will give something which has got the least chances of having all these complications of transfusion, and I will come that to in a moment. Okay, so starting with the first thing is, what is massive blood loss? Like somebody who is bleeding from the finger and somebody who is bleeding from the, let's say, from a major vessel. What is considered as a major blood loss? Now, there are different definitions. This is one of the most confusing part of massive transfusion protocol, and that are the definitions. Some say if somebody needs more than 10 units of blood in 24-hour time period, like, somebody is needing this over a 24-hour time period, that is massive blood loss. Or what you call, you have replaced a full volume of blood, like the adult blood is around 5 liters. So let's say in an adult, you have given 5 liters over the 24-hour periods. So you've already replaced a whole volume of the blood in the individual. That is massive. In kids, it's a different story. Like a neonate would be having at maximum 300 mils of blood. If you go a little like infant would be probably having up to a liter of blood. And, as the age progresses, then they've got more and more volume of the blood. So let's say even a small saucer of, like, or like a very tiny cup of blood loss in a neonate would be considered as massive blood loss. So there are various definitions of major blood loss, and they're all very confusing. Like one definition, they say like blood loss of greater than 20 mils per kg in 1 hour. So in 1 hour, let's say if there's a 10 kilo child and he has lost more than 200 mils, okay, that would be probably a small glass of blood. That would be considered as massive blood loss. Or any type of blood loss which leads to an increase in heart rate and decrease in blood pressure. In other words, shock, irrespective of whatever amount of blood has been lost. So if that leads to increased heart rate and decreased blood pressure, that is also massive blood loss. But the question is, in an emergency setting, it's very confusing. Who has got the time to measure how much blood is being lost per kg per minute? This is not possible. I mean, it's all like useless in an emergency setting. In emergency setting, they say any child who has got bleeding related to major trauma. So he's been bleeding from, let's say, a lacerated wound, like a sort of a jagged wound, where either a major blood vessel or a medium-sized blood vessel has been hit and he's bleeding. Like, for example, this can occur in knife injuries. This can happen in gunshot injuries, or sometimes a child who has got a chronic illness like cirrhosis, and he suddenly starts having massive hematemesis. So he vomits, and let's say a whole cup of blood comes out. So that should activate, that rather coming to activation later on, that is actually classified as major blood loss, because these are two different things. Major blood loss is one thing, and activating major transfusion protocol is another thing. Do not like confuse them with one another. They're not the same thing. Major blood loss is one thing, and activating MTP is another thing. It does not necessarily mean that if you've got major blood loss, you would always activate MTP. Depends. So irrespective of these definitions, like how much blood has been lost, like 20 mils per kg, or more than what with some definitions, they say like a loss of more than 40% or 30% total blood volume. This is all like rubbish. Nobody has got the time to measure all these things. Very simple. If somebody is bleeding and that bleeding leads to decreased blood pressure, increased heart rate, weak pulses, that means major blood loss, number one. Number two, if somebody comes with a trauma case, has got, let's say, open wound to the periphery, blood spurting out, that is major blood loss. If somebody is bleeding where the bleed, let's say on the floor, like, the bleed goes on the floor, on the bed, and let's say you look at the floor, it's like a sort of a pool, small pool on the floor for a child. I'm talking about child, I'm not talking about adults. Small pool on the floor, or is equivalent to that of a small saucer, like the size of a saucer for a, let's say, infant, or about the size of a glass for like school children. That simply means major blood loss. For ED, this is the definition: whosoever comes with bleeding, has got evidence of shock in the form of increased heart rate, decreased blood pressure, weak pulses, that is major blood loss. Somebody who's got visible blood spurting out, pooling on the floor, that is major blood loss. Somebody who's got polytrauma, bleeding from it, like knife injury, things like that, that is major blood loss. So whenever there is major blood loss in an ED setting, remember that should automatically trigger. The next thing is to activate the major transfusion protocol. Now, the major transfusion protocols, they differ from trust to trust. They differ from trust to trust. The principles are the same, but they differ from trust to trust in terms of what numbers have to be dialed, how much blood would be given, like how much units would be given in the first go, then. But to give you the overall principles of major transfusion protocol, basically, major transfusion protocol is an algorithm in which you just tell the hematology or tell the blood bank that they should give you an uninterrupted supply of blood. Uninterrupted supply of blood. Why? Because the patient life is in danger because of the ongoing losses. So they will keep giving blood to you or blood products to you till you sort of, call it off. So once you activate it, blood is going to come your way. The blood would come from wherever they arrange, the blood is going to come your way, and it would not stop unless until you tell them to stop. So you put them on hold, or you just like cancel the MTP. That's it. So some people think that MTP should not be triggered unnecessarily because it leads to waste of the blood products or things like that. No, it might lead to waste of resources, your resources. But remember, if blood comes your way and you don't need it, within 2-3 hours, that can be sent back. Remember, because when they come in special refrigerated like containers. So they've got special seals on them. So once you open it, and if you don't use it, you've got like a couple of, I think it's probably 3 or 4 hours in which you have to either use it or send it back to the blood bank. So if it's got sent back to the blood bank, they can refrigerate it back and it can be used later on as well. So the footnote here is that any major trauma, any major blood loss based on the criteria that I just told you should activate the MTP. So the principles of the MTP is that you activate the blood bank so that they prepare the blood products and they send it uninterruptedly through a dedicated, person towards you till you ask them to stop. So they are working on the back end, preparing all this thing on a continuous basis as long as you need them. Once you call it off, they won't send it anything back, and if anything is left with you and it's within its time frame, it can go back to be used for someone else. So I've told you the definition. Forget about how much blood per minute, like different books say different things. Just remember, for the sake of simplicity, in ED, these definitions, how much blood loss, they do not matter at all. Any blood loss with decreased blood pressure, with increased heart rate, with weak pulses is major blood loss. Any polytrauma, bleeding, making pool of blood on the floor is major blood loss, and next step should be activating the major transfusion protocol. Now, while you are doing this, because now here starts the the practical framework. So normally, if you see somebody bleeding, remember, while you think it's major blood loss and you activate it, but you'll not be sitting there, okay, well, fine, just wait for the blood. And the most important thing is to control the source of bleeding because still it's going to be time. It's not like you order it and within seconds the blood would be at your bedside. It's going to take some time. So you have to do some source control. So source control means wherever the bleeding is coming from, that should be controlled. Like for example, if somebody is having like massive epistaxis, so that needs to be packed, so you put some pressure on. If it is a limb one, so you need to put direct pressure on that. So tourniquet, like proximal tourniquet, like a very tight one, so that at least it squeezes the blood vessel, so at least the ongoing losses are minimized, if not like fully stopped. So it's important that while you activate it or somebody activates it, those people who are present on the bedside, because remember, this is not a one person job. Let's say, God forbid, if we ever get this thing in our ED, we would need every person on the deck to be available for this thing. So probably we'll have to close down the ED for everything else, okay, wholly solely focus on this thing, because you would need pair of nurses, pair of doctors. It's not a one doctor job, it's not like one nurse job, it's not a one CSW job. Everybody who's there in needs to rush in, and the different roles are assigned, and different things would have to be done by all these people. So it's a teamwork. So you need to control the bleeding. So whosoever is dealing like medicating at that point in time needs to put a tourniquet or like pressure or whatever, like depends on the which part of the body is injured. Based on that, you would be able to put either direct pressure or apply tourniquet, or if you think it's like a unstable pelvic fracture and is bleeding inside, you would probably need to put them in a pelvic binder, all these types of things. Number two is also the ABC. So while you're doing these things, never forget the ABC. So we have to secure the airway. It's better in major blood loss that they are tubed as quickly as possible. Why? Because at some point in time with major, eventually things would be deranged to some extent, and they would have to be tubed. So it's better to take care of the physiology there and then, because with that you can control the ventilation and all those things. So obviously anesthetists need to be there to do this thing. You need to have good vascular access, because now you are activating the transfusion protocol, so you need large bore access. So large size cannulas, at least an 18 size, like in older children. I know, and in smaller children it would be very difficult, so they might have to do a venous cut down or might have to place a central line, but in older children at least minimum of 18. In adults they can go up to 16 or 14, because you need large bore. Blood is quite thick, it's not easy to flow through the very small cannulas, and can break basically. So the RBCs, mechanical sort of destruction to the RBCs can happen if you are using very small cannula. So big cannulas have to be used. If nothing else, intraosseous access, that's the sort of that can save you the day, at least till you are able to get some major vessel access. So remember, the ABCs we talk about in medical cases, here is CABC. So you have to start from circulation. Here the circulation means like the peripheral part where the bleeding is occurring from. So let's say if he's bleeding from limb injury, you put a tourniquet or you put pressure on that, and then you'll go to airway, breathing. Again, coming back to the general circulation like blood pressure, things like that, IV fluids, till you are able to get bloods and products and you can give it to them. So the immediate actions are the same that would be done in case of any emergency, with the exception that here the first thing should be to control the source of bleeding. That's it. Okay, so while you're doing this, normally activation of the MTP is one person has to be dedicated for that. Now this is the protocol, this is the standard procedure all over England, Scotland, Wales. So in the whole team, one person, let's say it could be a nurse, so the team leader, whosoever is like, let's say a consultant is like leading the scenario, this case. This is okay, let's say Katie, you be the nurse, okay, who would be the in charge of the blood. So what you do is basically you go, you dial 2222 and you say, I'm activating the major transfusion protocol in, let's say, children's ED room number 6 or resus base 7. And now, and you then they will ask you for certain details, okay, that okay, what is the name of the child, other things. But anyhow, in the meantime, what they will do is that they will activate the blood bank. So the switchboard, what they do is they usually bleep, like it's a sort of not the usual bleep, like the voice bleep, the blood bank, and the blood bank would start working on. The blood bank also requires certain information. So they would relay back a form. So what you need to do is, number one, it also the switchboard, they do two things. Number one, they call the blood bank. Number two, they dedicate a porter, a dedicated porter. So this porter would be the person whose name is relayed back. He would be the one who would be running between the blood bank and between the, what you call, the actual bay where the emergency is being handled. So he would be the one who would be taking the forms and bringing blood, the bags of the blood, whatever is required at that point in time. And then there are certain other paperworks which would be done in the mean course of time. But in very simple words, one person is dedicated. They just dial 2222. They activate the major transfusion protocol, giving them the details. The switchboard tells the blood bank and dedicates a porter. So the porter comes, and the switchboard tells you that this is the name of the porter, I think, and he will be coming your way to do all these things. So that porter would be then the liaison person to run back and forth. So what they do is, normally your job, once you have activated the major transfusion protocol, is just wait for that. You don't need to tell them, oh, I need this or I need that. No, it would automatically come your way. You don't have to remember these things. It comes automatically in preform bags. One thing that you must need to do before this blood comes to you and you start giving it is taking blood samples. Obviously, for different things, you need to take at least a blood gap. You need these pink bottles for group and save and cross match. This is important, because once, if you have started giving them the transfusion and then you group and save, you don't know, because then the bloods would be mixed. So you don't know what is the actual blood group of the patient. So you never know. So it's better before, the blood comes and you have taken these pink bottles. Obviously, you need 2 of them for group and save and cross match, so that at least, they can match it and see that appropriate blood is given to you. But nevertheless, what they do, because it would take time, usually the first pack is always O negative. Why we give O negative? Because O negative blood, they have an O blood hasn't got any antigens on them. The O red blood cell, let's say this is the red blood cell, and the A blood group has got the antigen A, blood group B has got the antigen B. Okay, O hasn't got any antigen. So O hasn't got any A or a P antigen. So when there is no antigen and it goes into the recipient, so the recipient antibodies are not going to hit anything, because there is no antigen to hit. There is no target to hit. So that's why, to start with, we always give O negative packed red blood cells. Later on, when you have got this group and save, you can give the blood group matched RBCs as well. Let's say the patient is A positive, you can give them A positive later on. But the first pack would always contain what? Red blood cells which are O negative. And not in every trust. They say, I'm not sure about our blood bank because we don't have a proper, I've seen, I couldn't find anything. But the the east of England one, the protocol, they have got this thing. In the first one, they give this fresh frozen plasma 96. It comes under the name of Octoplus. But some labs, they take time, because fresh frozen plasma, because it's frozen and you cannot put frozen thing into the the veins of an injured person. You have to warm it up, and warming it through a warming machine takes at least half an hour. So you have to bring it at body temperature 37 degree. So from frozen 0 degree to bring it to 37 degree would take at least half an hour. So some, they have got this thing where they can quickly thaw it. There are new machines which can quickly do that, and they can just give you the first pack, the red, the box, which is the refrigerator box. It comes, and you break the seal, you open it, and you will see that there are a few units of red blood cells and the equal units of Octoplus. It depends. Some have got 6, some have got 4. Pediatric bags might be different from the adult ones. Depends. This can vary from trust to trust. But the principle is that it would either contain just O negative red blood cells alone, or it might contain a combination of O negative red blood cells, packed red blood cells, and fresh frozen plasma in 1:1 ratio. So Let's say you've got 4 units of packed red blood cells, you've got 4 units of fresh frozen. You've got 6 units of packed red blood cells, you've got 6 units. So it's just like 1-to-1 ratio. But as I told you, that once you have activated this, after some time you will get another bag, unless until you tell them that I'm holding out, I don't need any further because my patient is stable now, we have controlled everything. You will see after some time the porter will bring this bag number 2, and when you open it up, you will see that the second bag has got now packed red blood cells, it has got fresh frozen plasma, it has got platelets, or if you have requested, it might include cryoprecipitate as well. That includes fibrinogen. So, and if you need further, what would they do? They would be like alternating this. So pack 1, pack 2, pack 1, pack 2, this would be coming all your way unless and until you tell them to stop, or you have controlled the bleeding. Your patient is stable now, you don't need it anymore. So you will call them back again and say, I am stopping the major transfusion protocol at this time. This is, let's say emergency department, research base 7 or whatever, is the location of the emergency. So again, to summarize, you activate, and automatically once you activate, your job is to take bloods, and the most important where you will be doing routine bloods, because you have to take blood gas, you have to look at the lactate level, how is the perfusion level, things like that. You also have to do a coagulation profile, because later on you have to see if the coagulation profile is deranged, you might have to give further of these fresh frozen plasma and maybe cryoprecipitate. But the most important thing here are the pink bottles, and that is for group and safe. Very important, cross match and group and safe. This is important because if you forget to do it later on, there is no use of doing that, because you will have no idea what the patient blood group was, and you will have to continue with these things. The O negative thing, it will be just a wastage of resources. So these are the what you call steps in activating the major transfusion protocol. So how do we give them? Let's say it has come your way, blood bank has done their job. Usually the best way, there are different sort of researches on this thing, and most of the data comes from war zone. So the American soldiers used data from their wartime experiences in Iraq, in Afghanistan, and they found out that in a very emergency situation, especially in war zone area, the best thing is whole blood, because that is where they would, in in desert scenarios and things, you don't have these blood banks and things like that, so probably you have to rely on that thing. So in an emergency situation, and if available, whole blood is still the best one. But in a controlled situation where the whole blood and the sort of problems associated with whole blood refrigeration, because of the shelf life is different for different products, you will go with the blood product administration rather than whole blood. So the best thing is that they say mortality is reduced if you keep the ratio of 1-to-1 to 1-to-1. So that means 1 part red blood cells, 1 part fresh frozen plasma, 1 part cryoprecipitate, 1 part platelets. Basically, I would say platelets first and cryoprecipitate later. But let's say if it is not possible, then you can also have 2-to-1-to-1 ratio, where 2 parts of packed red blood cells, 1 part of plasma, 1 part of platelets, plus minus cryoprecipitate. So the best is 1-to-1-to-1 ratio, but if not, 2-to-1-to-1 is also acceptable, though they say mortality is slightly increased in 2-to-1-to-1 combination as compared to 1-to-1-to-1. But again, the results are statistically insignificant. That may be because of chance. So usually the blood can be given anywhere between 10 to 15 or 10 to sometimes severe hemorrhage 10 to 20 mils per kg. But usually in children we give it in small amounts. So rather than giving it one like whole big syringe like 20 mils per kg and infusing like let's say 200 mils in one go, you will use like small aliquots. So from the blood bag, small aliquots are made 5 mils per kg. So let's say for a 10 kg child 50 mils, so we inject 50 of that. Okay, and let's say you've given 51 and 52, so after that you need to balance it with the fresh frozen plasma. So if the first one only contains packed red blood cell, you will give it. The next one, when it comes, let's say you've again given like 5 mils per kg aliquots, then you have to balance it with the another like same amount of fresh frozen plasma. So the fresh frozen plasma and the RBCs have got the same amount. So if you remember 10 to 20, this is the magic word, 10 to 20 mils per kg. This is for red blood cells, this is for fresh frozen plasma. Okay, the lower side 10, the rest 10 can be used for cryoprecipitate and platelets. So platelets and cryoprecipitate are given in less amount, 10 mils per kg for platelets, 10 mil per kg for cryoprecipitate of fibrinogen. But the packed red blood cells and plasma, which is 45 and 55% of the blood, they are usually given 10 to 20. But that doesn't mean that you have to go in one. In kids, you have to be careful. The smaller they are, you have to go in small, because sometimes pushing too much can also be detrimental, because the body cannot handle it. It might lead to overflow in the lungs, okay, and that can lead to transfusion related acute lung injury, that can cause sudden damage because the perfusion is low. So what would happen? On top of it, you infuse blood so what happens is that the protein degradation in the kidney that increases, and that leads to acute renal failure as well. So one still has to go in small amount. That doesn't mean that you keep it, okay, well, you will transfuse it in the next 4 hours. It's not the routine transfusion for, let's say, anemic child or something where you are waiting for 4 hours. You still need to give it as quickly as possible, but you have to give it in small amounts rather than, giving like, it's not a bolus, like, you take a brick syringe and you just keep on pushing. You'll have to take small amounts. You give one by one, one by one, one by then. So that's the way it is given in pediatric practice. So irrespective of whatever, protocols are followed in any trust, it's very simple. 10 to 20 is the range for red blood cells and plasma. The other two small elements of the blood, that are your cryoprecipitate and platelets, that is 10 mils per kg. But again, they would always be given in small aliquots. So they're not given like pushed boluses. You have to give them like one by one. So you got the first bag, you give it in small aliquots, done. You will just mark it like with what you call with a permanent marker. Bag one gone. Next bag comes, you take it, you give the packed red blood cell, and then with that you've got 1:1 ratio of the octoplas or fresh frozen plasma. You give it, and then you check fibrinogen levels less than 2. Okay, you say, okay, let's give him some cryoprecipitate as well. And at the same time, at the end of, like, once you've given the packed red blood cells, you've given the fresh frozen plasma, you also give like 10 mils per kg platelet. So you, by the end, you just maintain this 1 to 1 to 1 ratio. Is as simple as that. 1 to 1 to 1 ratio, or 2 to 1 to 1 ratio. This is used everywhere. It's either 1:1 or 2:1. Sometimes tricky situations can arise. You have used 3 or 4 bags that has come from blood bank, and the bleeding still continues. Bleeding is still not stopping. It has reduced, but still. In that particular case, what we do is we ask, like, it's not the nurse's job, it's basically the doctor's job to think about this thing, and they go back and they ask the switchboard to connect them to the consultant hematologist, and they say the MTP has been activated. We had got 3 sort of lots of bloods coming in, and the bleeding is still going on. I would be requesting factor 7A, recombinant factor 7A. So factor 7A is basically the factor which actually controls the extrinsic coagulation pathway. And extrinsic coagulation pathway is whenever you damage, let's say, limb, like for example laceration, things like that. So your blood touches the tissue outside of the blood vessel, so that factor 7 gets activated. So what happens when you have got, like, let's say a cut, after some time that bleeding stops. Let's say kids who have got bleeding on the, let's say, laceration, the forehead, after some time a clot becomes firm clot. You when they come to you, they're not bleeding anymore. They say they bled a lot, but now the bleeding has stopped without any pressure. Why the bleeding stopped? Because the coagulation cascade kicked in. Factor 7A started making the clots, and that caused like sort of a pressure on that area where the bleeding was coming from, and the bleeding stopped. So in that particular case, you might need factor 7A to promote coagulation. Also, the ATLS guidelines, advanced trauma life support guidelines, they say, and this is also endorsed by the Royal College of Pediatrics and Child Health. Once you've got this major trauma, let's say major blood loss, and you have activated the major transfusion protocol. While waiting for the blood, obviously you have done the first thing that kicks in, like, naturally, is that you're trying to control the source by putting pressure or applying tourniquet. At the same time, they say administer tranexamic acid. This is something which is available with us all the time. So tranexamic acid, 15 milligram per kg, 15 milligram per kg to a maximum of 1 gram for a child. 15 milligram per kg has to be given within 3 hours of the injury, and once you prepare it, you have to give it within 10 minutes. You have to administer that. So you will pair up, let's say for a 10 kg child, 15 by 10 would be 150. So 150 milligram of tranexamic acid over 10 minutes you have to, and after that you have to administer a continuous infusion of tranexamic acid as well. I think that's 2 milligram per kg per hour. So you have to maintain that thing as well. So that is separate from blood. Why? Because tranexamic acid actually promotes coagulation. So from wherever the bleeding is coming and you put pressure, it would tend to clot, and that clotting would be promoted by tranexamic acid. So the more clotting, occurs at the site of the bleeding, it would stop the bleeding. So obviously you give blood because the blood that has been lost, you have to replenish that. But at the same time, you have to close this gap as well. Otherwise, whatever blood you are giving is coming out. So you are just imagine somebody who is continuously bleeding, you are putting blood into them and they are losing that blood. By the end, they will still die, and that would lead to loss of blood as well. That the blood bank blood as well, because it's going in, it's coming out. So it's very important that you try to control that injury, okay, and promote coagulation at that point. And that can be done by various things. Obviously, when you give these clotting factors, I think they also promote the natural clotting. But if you specifically give factor 7A in huge amount, that's gonna act, that would just make the blood quite thick, and that would have got more tendency to clot at the area of the injury, and that would plug that part from where the bleeding is occurring, and more chances of bleeding getting stopped. So source control, and number 2, tranexamic acid. Tranexamic acid dose is 15 milligram per kg. This is again endorsed by 2 authorities. Number 1, ATLS, the Trauma Life Support Group, and number 2, Royal College of Pediatrics and Child Health. So they both say 15 milligram per kg over 10 minutes within 3 hours of the injury or of the accident, followed by 2 milligram per kg per hour infusion. Okay, let's move on. Oops. Yeah. Okay. So then there are other things as well. It's not only blood loss that you're worried about. When you are giving these blood products, they can have their own issues as well. Blood, when you give this packed red blood cells and thing, that contains citrate. That contains citrate as a preservative. When you give that packed red blood cells and you are putting it in the body, a lot of citrate goes inside. So what does citrate? Citrate binds calcium in your blood. So when calcium is bind to citrate, the calcium in the body goes down. When the calcium goes down, that is called hypocalcemia. Hypocalcemia can be detrimental because hypocalcemia can cause hypocalcemic fits. Number 2, hypocalcemia can cause what? Arrhythmias. You don't require any of them. That would be the worst thing to have in a bleeding patient who is bleeding at the same time and now goes into cardiac arrest or develops fits as well. So if the ionized calcium is less than 1 millimoles, you can do it on a blood gas. You have to give calcium gluconate. 10% of calcium gluconate, usually the dose is 0.5 mils per kg. At the same time, you have to be careful about hyperkalemia as well. All blood products, they contain some form of potassium inside. So there can be an increase in potassium. You have to give occurs rarely, I would admit that it occurs rarely. It's not that very common, but if it increases, like let's say the potassium level increased potassium itself can cause arrhythmia. So in that particular case, like the best thing to decrease is giving them insulin with dextrose. Obviously if you give insulin, that's going to cause hypoglycemia, so that's why insulin is given with 10% dextrose So they balance the effect of one another, and at the same time, insulin, because of its effect on the potassium, causes potassium to go inside the cells and decreases the level of free potassium in the plasma. So hypocalcemia, hyperkalemia, and the third thing is hypothermia. Hypothermia is also important thing, because those, these patients who have got injuries, they would be usually exposed. You like tear them off their clothes and things, and they can get hypothermic very quickly. So hypothermia itself, causes, leads to problems with the coagulation cascade. So coagulation would be very poor if the child is hypothermic. So you need to increase the temperature of the environment ambient, so that they do not become hypothermic. So hypocalcemia, hyperkalemia, and hypothermia, these are the three adjacent things associated with major blood loss that one has to think about. So it's not only that one gets focused only on the blood, you also have to think about, because remember, this triad, this dangerous triad, you have got acidosis, you've got hypothermia, and you have got ongoing blood losses, okay, which can be this like triangle. When it's there, that can be very, very much, dangerous for the child, for the patient, can cause increase in mortality. You have to ensure that acidosis does not happen. That's why while you are waiting for the blood and you are doing all these things, you can start them like on IV fluids as well. So, but the only one thing ATLS recommend, that you should not go for more than 20 mils per kg of IV fluid, because if you give more than that, what you are doing is you are diluting the blood. So further dilution would lead to dilutional coagulopathy. All the the clotting factors would be consumed. So in trauma, fluid has to be given very carefully. You have to give it in small amounts. In children, they say 5 or 10 mils, but you can go stepwise, not to exceed 20 mils per kg. If you reach 20 mils per kg and the child is still hypotensive, that's the indication you have to go towards the blood. No more further fluids, just blood. Okay. So hypothermia manage, I've already discussed this thing. So the goals, like when you are monitoring, everything is going on, patient starts becoming stable. So there are a few things that we have to ensure that these goals are met before we can stop the MTP. So the hemoglobin should be greater than 80 grams per deciliter. The platelets should be at least 75. Fibrinogen level should be more than 2. INR should be less than 1.5. Temperature should be more than or around 35. Lactate should always be less than 4 millimoles. And pH should be around 7.2. Do not let it go below 7.2, because of the, let's say you think like the patient is improving, the pH is 6.9 or something, it can still be, because you will think the patient is improving, and within half an hour, like you, again, the whole cascade, the clot would be dislodged, he would become further hypothermic, the bleeding would restart. That's why you have to ensure that these goals are being met. So they have to be constantly. So you will be taking bloods, every hour, okay, and looking around these things, at least a blood gas, okay. Though platelets would not be, you can't see platelets on the blood gas, though I think there are new blood gas analyzers that can not only give you the platelets level, they can also give you the CRP levels, and I think the new ones. Obviously CRP is not like sort of anything which is related in this particular scenario, but they can give you a lot more parameters than what you get on these conventional blood gas machines. So anyhow, so these are the parameters that has to be ensured that these levels are being met before you can call off the MTP. So obviously, if somebody is bleeding despite having all those things and you're scratching your head, what is happening, you have to escalate, or the doctor has to escalate it to the hematology for recombinant factor 7A, and that also might be a sort of a call for the surgeons as well, because there might be something more than that, and surgeons might have to intervene either to ligate the blood vessel, or simply if an organ is too much lacerated, they just have to remove the organ. They like a spleen, they might have to do splenectomy, things like that. Remember, if there is a delay in the blood products, certain EDs, they have got their own fridges as well, and that they have got a little bit of like stock for emergency purposes, and O negative packed red blood cells can be used from the nearest fridge till you are able to get it from the blood bank. And best thing is to infuse it through IO if you are not able to get a good vascular access. The key takeaways for this lecture is that number one is early recognition. So as I told you, forget about these how much blood loss being per this mil per kg per hour. Just remember, any child with bleeding who has got deranged hemodynamic status or has got a visible pooling of blood on the floor because of whatever injury, that simply means that you have to activate the MTP, because that is considered as major blood loss. Once you have done it, you have activated it, and you do your job. That would be controlling the source of bleeding, securing airways, establishing in good IO or IV access, activating code red or this cardiac arrest call, whatever, or trauma call. You have to continuously monitor by checking the labs hourly and making sure that the targets that I told you, that the hemoglobin, pH, lactate, especially, they have to be maintained. The most important thing among all these parameters is number one, that hemoglobin should always be greater than 80. Lactate should not be more than 4 because it simply means hypoperfusion. And the pH should never go down, because acidosis is the worst thing that can happen in this scenario. And remember, when you're using blood products, they are always used in 1:1 or 2:1 ratios, depending on your trust guidelines. But you don't need to worry about that because the bags come pre-formed. So when you open it, everything is there for you. You just go one by one. So you pack blood cell, one packed red blood cell, one fresh frozen plasma, one platelet, and if fibrinogen is down, you can give one cryoprecipitate as well. So as needed, you will do this. Continuous monitoring is very important. If the child is still bleeding despite having repeated this bags of transfusion, the doctor has to talk to the hematologist for requesting recombinant factor 7A that actually promotes coagulopathy, and at the same time invite the specialties like, let's say, interventional radiologist or surgeons to have a look, because the child might need to be taken to the theater to do damage control surgery, okay, remove the organ or ligate the blood vessels to further control the source of bleeding. So this was all about the massive blood loss, massive hemorrhage, and the massive transfusion protocol pathways